it's really a privilege to introduce Dr. Emily Summers, who is a member of our While at School subcommittee. Dr. Summers comes to us from the University of Michigan, and we're very grateful for all the expertise that she brought to the While at School subcommittee, which was a really important team for our task force. So Dr. Summers, I'll let you take it away.
Okay, thank you. And I have lost the picture as far as the videos. Can you see me or can you hear me?
We can hear you clearly, but.
Okay, wonderful. Okay, so welcome everybody, and thank you for having me this evening. I want to give my strongest gratitude to Superintendent Merritt and the board and everyone in the district for your dedication to making these difficult decisions. So my role on the subcommittee is that I'm an epidemiologist. I'm currently an associate professor at the University of Michigan. I'm also a district parent of 3 girls in the elementary and middle school level. And as far as my training, I did my master's in epidemiology at the Johns Hopkins School of Public Health and my PhD in epidemiology at the London School of Hygiene and Tropical Medicine. So since March, I've been working in COVID a lot in my current day job. And I've been running the hospital COVID registry there at U of M. And the information I'm going to be presenting tonight I've received input from a couple of colleagues who have expertise in infectious diseases and epidemiology as well. So my goal here is to provide the best and most up-to-date public health information that I can this evening to help support your decision making and to help you in the weighing of risk and benefit concerns. Next slide, please. And some of you would know me from leading the STEM activities at Byrd Elementary in the last few years. I've done the epidemiology activity, and it includes a really fun activity with a lot of glitter germs. So I always have to apologize for the remnants of glitter found in the classrooms for days afterwards. But anyway, I really enjoy helping provide the education for the community. And the information tonight is, of course, much more high stakes than I'm used to presenting, but it's really important, I think, to provide a fair amount of data so you can understand the complexities that go into the decision making. It's really not easy to make a cutoff or a threshold using a single data point to make decisions so important, such as the safety of putting our kids back into schools. So I'm just here to provide you with as good a basis for that determination as possible. Next slide, please. So this slide is only to distinguish between a couple of terms that are thrown around a lot interchangeably, so that we're all on the same page. The virus that we are talking about is the severe acute respiratory syndrome coronavirus 2, which is called SARS-CoV2. And the syndrome or the clinical illness that results from this virus would be COVID-19. So in this figure, you can see once you develop symptoms, that is when you would use the term COVID-19. Coronavirus disease 2019. Next slide, please. So I'll start by giving some basics related to transmission. So there are a few modes of transmission that we need to think about for SARS-CoV-2. And on the left-hand panel, you can see the very left-hand person in the figure is a depiction of somebody with the infection. So somebody infected with SARS-CoV-2 and who is infectious. And if this person coughs or sneezes or even speaks or participates in other activities such as singing, they can emit droplets, which are defined as those that are less than 5 to 10 millionths of a meter, or what we call a micron in size. So these droplets that can be emitted are heavy enough so that they would fall to the ground. If you would picture a ball as a trajectory that falls to the ground within a certain amount of distance, the droplets are heavy enough that they generally fall into the ground within about 6 feet. There is a continuum. There's no magic cutoff for how far a droplet can travel. So we think that 6 feet is a pretty good cutoff. And that is indeed the basis for our physical distancing recommendations. But I do want to underscore the point that there's a continuum, both in terms of droplet size and how far they travel. So the 6 foot designation really is not a magic number. And just to put in perspective what a droplet size would be, it's about 1/10 of the width of a human hair. So even a droplet, which in viral terms is large, it's actually very tiny. The second mode of transmission that we need to consider would be by aerosol. These would be droplets that are less than 5 to 10 microns and always dry fast enough, almost always dry fast enough to form droplet nuclei, which are the material after the liquid has evaporated, leaving suspended viral particles in the air. And these can travel at great distances in the case of some viruses. And these are sometimes also referred to as the airborne size range. So the proper term for droplet nuclei and the air that surround them would be aerosol. Diseases such as, or viruses such as the measles virus are notorious for being able to stay in the air and travel very long distances. With SARS-CoV2, this is a very active area of debate. So early on in the pandemic, the dogma was that it was predominantly only able to proceed by droplet transmission. However, there in the last few weeks has been increasing debate on this topic because it's a new virus again. We don't have all of the answers. So what we can be fairly confident in saying is that it's most likely less of an issue than droplets. However, we cannot eliminate the possibility of these tinier particles that travel farther distances. If you look at the very bottom of the picture on the left, you can see, again, there's this continuum where in the pink near the bottom, it shows the approximate distance that we believe the virus can take. And anything in the air is the concern there is that you could breathe that in. And the last mode of transmission that we know is a concern is contact transmission. This would be contact with infected people or contaminated surfaces or objects. And you would transfer the virus then by touching the contaminated surface or object and then transferring to a mucous membrane, being the mouth, nose, and eyes. And I'll specifically underscore that eyes are a concern for transmission as well as the nose and mouth. The eyes are not receiving as much attention as a route of transmission, but this is definitely an area of concern for viral transmission. And we know that we have learned that there are receptors in the eyes that can receive the virus. Next slide, please. So a bit more about droplet transmission and close contact, because I think this weighs in heavily into any decisions we make in terms of what are safe practices. So on the left, I have pasted verbatim from the CDC how they determine or define a close contact. So they say an individual who has close contact is less than 6 feet with 2 asterisks for greater than or equal to 15 minutes with 3 asterisks. And so I'm highlighting the nuance so you understand the uncertainty that we're dealing with. So the definition for close contact, the factors to consider would be proximity, the duration of exposure. So the longer the exposure, the more likely risk of infection. And whether the exposure was to a person with symptoms. So for instance, if you are near a person with coughing or sneezing, or even in circumstances like loud talking or singing, that would increase your risk of exposure. And then the bit with 3 asterisks is that the data are insufficient to precisely define the duration of time that constitutes a prolonged exposure. The recommendations vary, but 15 minutes has been used as an operational definition that a lot of people are comfortable with. So brief interactions are less likely to result in transmission. Next slide, please. And more on contact transmission, I want to emphasize that we all touch our face, not just kids. Even the Queen of England touches her face and has been caught on camera doing so. Just a few anecdotes or just small studies from the literature. One was that even medical students touch their faces an average of 23 times an hour, with just under half touching a mucous membrane. Again, the mouth, nose, and eyes are like the doors to your body for a virus to get in. 1 out of every 3 adults has been observed to nose pick or eye rub each hour. And another study found that people touch surfaces and their mouth and nose 3 to 4 times per hour. So the big point here is it's hard enough for adults. It's human nature to touch your face. And in the process of doing so, you contaminate fingertips, which can then lead to self-inoculation, meaning you contaminate yourself by taking a fingertip. You can, with virus, either touching a surface and letting it rest there for others to then pick up, or if you're touching your own face after touching another surface, that leads to self-infection. So with adults, it's hard enough. With kids, of course, it's an even greater challenge. Next slide, please. And this is also the basis of why we have to worry so much about high touch or high contact surfaces, things like doorknobs, electronics, elevator buttons, pens and pencils. And if you think about a classroom setting, even things like papers that you would be passing around and other sorts of materials, books and the like, we really have to be aware of the possibility of contact transmission through those types of items. Next slide, please. A bit more about incubation and infectious periods. On the figure, you can see on the left that incubation periods after exposure to the SARS-CoV2 virus range from 2 to 14 days. Typically, we believe 5 days is about the most common incubation period. And if you look at that orange arrow on the bottom, we see that there is a pre-symptomatic period before someone actually exhibits signs or symptoms, and that we believe lasts approximately 2 days. If somebody does go on to develop signs and symptoms, they are likely infectious for another 10 days for a total of approximately 10 days of an infectious period. And during this course of 10 days, that is when we have to worry about that person being around other individuals, or for indirect types of transmission, if they have touched objects then that other people then go on to touch. In the bottom left-hand corner, you see the iceberg concept that we use a lot in infectious diseases. Here at the top of the pyramid, you can see that for a lot of disease that's occurring, you would have the most infrequent outcome would be death, of course. And then you have a larger proportion of individuals exhibiting symptoms and with COVID-19 illness. But then underneath the surface is where we have a lot of undetected disease. So these could be pre-symptomatic individuals or asymptomatic individuals. And so the point here is that the disease that we can see is only a small fraction of what is actually percolating underneath the surface. Next slide, please. So epidemiologically, there are 3 categories of metrics that we use to help inform things like decision-making, to monitor disease and surveillance in the community. So the first metric would be the level of the disease, and the second is test positivity. Those are both indicators of epidemic spread. And the third is testing capacity, which is an indicator of public health capacity. And I'll go into more detail for each of these 3 items on the next slides. So first, to start off, would be assessing the level of disease in the community. The term that we use to describe risk or the level of disease in a population is incidence. So in the case of SARS-CoV2, we are using the number of new cases per million per day in a defined region to determine incidence. And I've underlined the word million because in case you are the type that looks at data across different states or different countries, you will find that the population denominator that is used it varies. So a lot of epidemiologists use 100,000. I've even seen 10,000, but because of the levels of disease that we're talking about, and at least within the state of Michigan, we want to make sure that we have a comparable denominator so that we can compare metrics across areas. So in the Michigan data, we'll be looking at the number of new cases per million per day in a defined region. And the region that we would look at to help inform the decision-making related to the Plymouth Canton schools would be Southeastern Michigan, particularly Wayne County. If you go to the mystartmap.info website, which I have the link on the right-hand side here, there's a lot of publicly available information. And the way they split out the metrics on that website in the relevant portions of Southeastern Michigan include Wayne County, excluding Detroit, the city of Detroit, Washtenaw County, and Oakland County. So on the following slides, I'll give you a bit of data related to Wayne County, excluding Detroit, just as an illustration, but we would want to monitor all 4 of these areas based on the degree of transportation and movement of people within these areas. So in other words, we may have students and teachers who are attending Plymouth Canton schools. However, they may have household members that reside in other regions. We have school of choice participants. There's a whole lot of reasons why we don't want to only look at Plymouth and Canton statistics. So the incidence, oh, sorry, if you can just go back one more time. Just to go back, one more thing about the incidence is that one of the ways that we look at this in the setting of an epidemic is to look at the 7-day average. And so the risk thresholds that I have listed below are what have been determined to as useful in the state of Michigan. And these metrics have been informed by the CDC. And these do get periodically updated. And I made sure that all the information in our presentation today is up to date as of a couple of days ago. Okay, next slide, please. So another way to look at incidence is to look at trends. So instead of looking only at today or only at yesterday, we want to look at trends that give us an idea of a longer time period. The table I have here gives you an idea of the different ways we would use the trends to assign a risk level. An example of a couple of rebound markers that would be causes for concern would be is if we see a 5-day sustained increase, or if on 3 consecutive days we see a 10% increase in new cases, and that would be a sign of an early signal of sudden increase in infection. One marker of improvement would be as if we see 4+ weeks of sustained decrease in the community. Next slide, please. So locally, I've presented here the Wayne County excluding Detroit data. Of course, I mentioned we would look at these other neighboring areas, but for the sake of simplicity here, I've just pulled the Wayne County excluding Detroit. So on the top, we have a graph since the beginning of the first cases which arrived in Michigan in March. And I think March 10th was the first confirmed case in Michigan. And you can see, of course, there was explosive growth early on in the pandemic locally. If you look on the right-hand side of the graph, although we have seen a lot of decrease, which is encouraging, the rates in recent weeks have been creeping back up. And now, even though they don't look anywhere near as high as they did a few months back in March and April, we still are around that threshold of high and very high incidence. So that's a concern. On the bottom right-hand corner, I have, we've zoomed in on the last few weeks to give you a better assessment. So you see several days where we've reached that 70 cases per million threshold per day. And on the left bottom hand corner, I put an example of the very local data. So I've listed Canton, Plymouth City, and Plymouth Township. And I've done this for a couple of reasons. The first is because a lot of people would say, well, why do we care about the disease outside of our immediate community and outside of our school district? And aside from the concern for people moving in and out of these areas, I want to also drive home the point that the smaller the population denominator, the more likely it is to have a single day or a couple days worth of statistics really cause a blip in our understanding of disease. So for instance, Canton on August 2nd was in the medium high risk category, or excuse me, I believe that was the high risk category, whereas on the 3rd of August, it was the medium risk category. So just within one day, you saw the cases per million going from 64.5 to 10.8. And that's a very unstable estimate, which is why we need to look at a longer time period. Similarly, Plymouth City, the estimates were much, much higher than Canton. And then Plymouth Township had a day of 0 cases, which meant their risk was in the low category, followed by just one day later when they reached the very high category. So what we really want to do is take a more holistic viewpoint. So at the bottom, I have the 7-day combined average for the Canton, Plymouth City, and Plymouth Township areas. And it hovers more closely to what the Wayne County levels are, around mid 40s per million. Next slide, please. So the second metric, test positivity. This is an indicator related to whether communities are conducting enough testing to find cases. This is a somewhat difficult concept for some people to get their heads around, because some people say, you know, there's so much that can influence the test positivity rate. What does it really mean? So I'll just walk you through a few considerations. So this metric is measuring the number of positive tests per total number of tests. Once testing levels are stable in an area, this metric also identifies increases or decreases in the epidemic relative to other causes of respiratory infection, is commonly used, for example, in surveillance for influenza and other respiratory viruses. And in fact, a percent positivity above 10% in this metric is common for signaling what is the beginning of an influenza season. And that would rely on a system where testing patterns are remaining fairly constant. As the epidemic decreases, we expect this metric to decrease as well. And both the actual percent positivity and the trend are informative. So down below here, I have a couple examples. Generally speaking, if you have a high test positivity level, it suggests that the community may largely be testing the sickest patients, which is not what we want. We want to be including people who wouldn't be rising to the top of that iceberg that I showed you before. We're possibly missing milder or asymptomatic cases if the test positivity rate is high. And one example of how we can, why this is important is that if greater than 7% of tests are positive, the true level of active cases is probably tenfold or higher. Conversely, if the test positivity rate is low, it could indicate that community is including patients with milder or no symptoms in testing. Next slide, please. So in our region, again, I have a graphic here pasted from the MyStartMap website, so publicly available data that you can access on a daily basis. At the top, we see that tests in the area have been on average over the last 7 days around 5%. We really want to see these rates getting to lower than 3%. And an indicator of low risk that we would use would be less than 3% and a decrease, a 2 to 4 week trend of decrease. Next slide. And the third metric is testing capacity. So this includes constraints on who can get tested. Are there supply shortages? It's really a measure of our public health system and how we can handle an epidemic. Short-term testing goals, such as 1,500 tests per million per day, are common in many states. If they drop below that, we worry that we don't have enough testing to meet our basic needs. And in our region, the recent 7-day average was 2,600 tests per million per day. So at the moment, we seem to be doing pretty well on this metric. We also need to understand turnaround time. This information is a little bit more difficult to access, especially in real time. The time, the two components of time include the time from symptom onset or the identified need for a test to the ability to obtain a test. And in relevance to our pediatric populations, I would mention that a lot of sites do not offer pediatric testing. The swabbing to do that properly can be more challenging in kids. So from a practical standpoint, if you have a kid who needs a test, often it's much more difficult to find them a test on a weekend, and you may only have 4 days a week, for instance, where you can find an option for their testing unless they're in the severe illness category, in which case then it would probably be easier to find a test. And then the second component of time is the time from having the test or the nasal swab to obtaining the result. And in the state of Michigan, the average, I am told by my colleagues, is 3.8 days currently. However, there is a very wide range, with some labs taking 8 to 10 plus days to report results. Next, please. And lastly, these are more difficult to quantify, but there are other public health capacity indicators that would be secondary considerations. These include case investigation capacity, which is the first step in providing isolation info and resources to the case and obtaining context, which would then allow us to slow transmission. And then the second part to this is contact tracing capacity. This is eliciting the context of confirmed COVID-19 cases or those who test positive for the virus, and monitoring those other individuals daily for the onset of COVID-19 symptoms. This can dramatically assist in driving down community transmission, prevent spikes in new infections, and is critical to the reopening of regions and keeping them open. So even though it's hard to get metrics and numbers associated with these two items, I would mention that this is going to be a role that our school nurses have a critical involvement in partnering with the county and state health departments. So we really have to understand the burden that would be put on our school nurses to participate in this process. Next, please. And I've brought here again the transmission timeline related to infection and incubation periods, but now I've overlaid at the bottom in lavender how testing capabilities play into this. So if you refer back to the bottom orange arrow where we talk about pre-symptomatic but infectious periods, there's not much we can do before a person has been identified as having a symptom, unless we're doing random screening of the population. But in the typical scenario where you have somebody who exhibits symptoms, it's very likely that it could be a day or 2 days before they are able to obtain a test to confirm whether they indeed have are infected with the virus and have COVID-19. When we enter flu season and the like, there's going to be a huge need to differentiate symptoms, respiratory symptoms, and other signs of illness between COVID-19 and the flu, RSV, and other things. So there's going to be a lot of symptoms floating around, and until we can get a test obtained, we won't know how to act on that case. So let's say it's a couple of days after the onset of the pre-symptomatic but infectious period when a person first gets a test. And then with our state median of approximately 4 days to getting the test result, we're talking about, in a good scenario right now, a total of about 6 days where somebody is infectious, but before they have been identified. And then at that point, contact tracing would hopefully initiate. But again, there is a lot of strain on the system. And so it's likely that you're going to have another day or two before an official contact tracing could be implemented. So I think we need to be thinking about this because, again, we want to understand if there's a suspected case in a classroom, even if they do not end up being positive for the virus that causes COVID-19, it will cause significant disruption until we understand what we're dealing with. Next slide, please. And just a couple things to point out how SARS-CoV-2 can affect children. Contrary to early reports in the pandemic where we were all kind of lulled into a sense of security that this was a very rare type of illness in children, and that those children who did get infected tended to have very mild disease, there have been some recent studies that call into question some of these early suggestions. So we are learning more and more every day about this new virus, and the recent data do indicate that SARS-CoV-2 infection can play an important role in transmission, and that kids can get infected, even if we're not seeing as severe disease in general. Next slide, please. Something that reached the news and the headlines that a lot of you may have heard about was last week, the reports from a Georgia overnight camp. So I'm bringing this up again to illustrate why we think that youth and pediatric transmission may be relevant. The first thing I would point out is in this camp setting, safety precautions were attempted. In fact, all trainees, staff members, and campers provided documentation of a negative test for SARS-CoV-2 within the 12 days before arriving to the camp. So they attempted to eliminate the possibility that they would introduce the virus into the camp. However, this did escape one person, and from the reports, it sounds like one person was infected with the virus, and within a short time of arrival exhibited symptoms, at which time they started shutting down and testing. However, even so, we saw that there was a really high attack rate. So in the table at the bottom, and the attack rate being the number of new cases for the total population in this camp setting, you can see that 50% of the youngest age group of 6 to 10-year-olds did end up getting infected. And then the rates were significant for the older groups, but progressively lower. So this was a little bit contrary to what we would have expected in terms of who is getting infected, who would then be infectious and can be transmitting disease elsewhere. So the kids in the 6 to 10-year-old age group, half of them in a very quick amount of time did get infected. And I'll also just mention that if you're wondering what's happening locally, or if you're thinking about an overnight camp setting being whether you can extrapolate to other settings, I would mention that there are a lot of outbreaks occurring. Only a fraction are reaching headlines, and there have been several outbreaks associated with childcare facilities, even in the state of Michigan. Next slide, please. And then just some other data that have come out in the last week or two to support the idea of infection and transmission in kids. There was a study that was well conducted from South Korea. And in this study, they showed that older kids who they define as 10 years and older are likely to transmit at the same rates as adults. And the 0 to 9-year-olds, so the lower kids, also did transmit the virus, it was at lower levels, but still significant. So the inference here, as it would relate to schools, is that transmission could be likely to be occurring between kids and teachers. We can't anymore ignore the fact that younger kids can be part of this process. And then another study from Chicago did some laboratory investigations showing that the youngest children, less than 5 years old in their study, had equivalent or more viral nucleic acid in their upper respiratory tract compared with older children, who they defined as 5 to 17 years old, and also more than adults. So again, suggesting that children can play an important role in the transmission of disease. Next, please. And a couple of other points. Again, a lot of the, I think, inference that was drawn early on in the pandemic was that the hospitalizations and severe illness were occurring in those medically vulnerable populations who have other risk factors. But I really want to make sure that no one is discounting the fact that everybody is susceptible, both for severe illness and prolonged illness. So on the left here, I have an example of a large study from Georgia showing that 1 in 4 hospitalized patients did not have a high-risk condition before they were infected and developed severe illness. And also prolonged illness is a concern. So another study has shown, and this was also data from the CDC published in their bulletin, that 1 in 5 previously healthy young adults who are under the age of 35 were not back to usual health within 2 to 3 weeks after testing positive. So we really need to pay attention to these data as we move forward. Next slide. And the last bit about the clinical concerns related to SARS-CoV2 infection. By definition, this is being a new virus, there are unknown long-term health effects. So we've already observed a lot of erratic clinical features related to this virus. Clearly, we are seeing more than simply respiratory illness that we would have predicted. We are seeing all kinds of things, including clotting and strokes, et cetera. And we've even seen lung damage associated with mild illness. So persons who do not exhibit severe outward symptoms, but who are developing some sort of lung involvement that we worry could set the stage for future susceptibility to things like respiratory disease or even asthma. We really don't know. And there's also been a very rare but severe syndrome reported in children called multi-system inflammatory syndrome in children, which can resemble things like Kawasaki disease and toxic shock syndrome. So while rare, we do not know which kids are the most likely to develop that. And then we also want to think about whether there will be post-viral syndromes or long-term illness. Again, being a new virus, we have no idea what we're dealing with. But examples from other viruses where there is precedent is seeing things like severe pain or arthritis as a post-viral syndrome. A lot of us are familiar with long latency of things like the virus that causes chickenpox, which can exhibit as shingles in adulthood, even if the initial course with chickenpox was uneventful. So we're hoping that we don't encounter some novel long-term consequences, but again, we don't know. What we have seen so far is something that is termed myalgic encephalomyelitis-like illness, which includes things like fatigue and brain fog, which we don't completely understand. But this is some of the newer type of things that we are seeing as we develop follow-up after illness. Next. So this is my last slide, and the point of this slide is to tie everything together. We want to make informed decisions. So at some point, we need to know when we are going back to school, what are the measures that we can take to protect us? And so tying together all the information about transmission, I really love this infographic because it highlights a lot of issues. So on the left, it shows that in order to be as safe as we can, we need to take some personal protective measures such as mask wearing. And I've added in eye protection, which was not on the initial infographic, but I really think that's important. Things that we all know about in terms of hand hygiene, the physical distancing of at least 6 feet is one of the best measures that we can take to protect ourselves. And also if there are engineering controls such as air filtration, that is also helpful. But this is all predicated on having low community spread, because once we have high community spread, there's really, these measures, while they can mitigate risk, are not going to eliminate risk. So then on the right-hand side, just so you can be thinking about the different types of activities involved with school. Some of the higher risk activities would be the school bus or public transportation if that applies. And then other settings such as locker rooms, or even high risk activities would be considered choir or wind instruments and things like contact sports. Whereas other ways to stay safer would be having desk-based instruction where there's not a lot of movement around the classroom, maintaining the 6 feet distancing at a minimum if possible, and things like outdoor playground time. Those are lower risk activities. So any decisions that we're making really need to use all of the epidemiologic data available to help inform how to do it most safely. So that's all I have. Thank you again, and I will turn it over to Kathy Adsett.
Thank you, Dr. Summers. Your contributions and work with our